Cardiac tamponade is fundamentally a mechanical problem. The accumulation of pericardial fluid under high pressure restricts the heart's ability to fill during diastole. This creates a state of fixed cardiac volume, leading to severe progressive hemodynamic compromise. Diastolic pressure equalization. The definitive hallmark of cardiac tamponade is the equalization of diastolic pressures. As intrapericardial pressure rises, it eventually exceeds the normal filling pressures of the cardiac chambers. During diastole, the right atrial, right ventricular end diastolic pressure, left atrial and left ventricular end diastolic pressures all converge to match the elevated pericardial pressure, typically 15 to 20 millimeters of mercury. This eliminates the normal pressure gradients that drive diastolic filling, drastically reducing preload and stroke volume. Normally, the right atrium fills during ventricular systole, producing the X descent on a central venous pressure tracing, and empties rapidly into the right ventricle when the tricuspid valve opens in early diastole, producing the Y descent. In tamponade, this filling pattern is severely altered. Prominent X descent. Atrial filling can occur during ventricular systole because the contracting ventricle briefly decreases in volume, creating a small amount of space within the tight pericardial sac. Blunted or absent Y descent. As soon as the tricuspid valve opens, the elevated pericardial pressure completely prevents the right ventricle from expanding. Early diastolic filling halts immediately, abolishing the normal drop in atrial pressure. Because the tense pericardial sac fixes the total volume of the heart, the left and right ventricles are forced to compete for space. This creates an exaggerated form of ventricular interdependence, clinically observed as pulsus paradoxus, an inspiratory drop in systolic pressure greater than 10 millimeters of mercury. In inspiration, negative intrathoracic pressure increases venous return to the right atrium and right ventricle. The septal shift. Because the right ventricle cannot expand outwards against the rigid fluid collection, the interventricular septum is forced to bow to the left. The hemodynamic hit. This septal bowing encroaches on the left ventricular cavity, severely decreasing left ventricular end diastolic volume. The result is an immediate drop in left-sided stroke volume and systemic systolic blood pressure during inspiration.